بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أبنائنا طلبة المرحلة الرابعة. We will continue in the second part of lecture of biochemistry. Estimated glomerular filtration rate, as mentioned in part 1, there is measured GFR that is inaccurate due to several factors. Of most important is time collection of urine over 24 hours and careful and accuracy in collection of that urine. So there is what is referred to estimated glomerular filtration rate. Firstly, urea, as mentioned, it is poor indicator of both measured and estimated GFR due to what? To high percentage of retaining or reabsorption of it proximally after filtration. Estimated glomerular filtration rate, it is approximate mathematical equation that relate the serum creatinine with GFR, and by it can exclude the confounding variables that influence this relationship, and that is found in measured glomerular filtration rate and also in measurement of direct serum creatinine. These equations are derived usually corrected for gender, for body size, for race, for age, for weight, and this usually for one or more of these factors according to the type of equation. In general, estimated GFR, it is a mathematical equation instead of the measured GFR. And by all of any of these equations, we will not need for urine collection over 24 hours, and we will not need for measurement of urine concentration of a biomarker for GFR. And by this way, two disadvantage: the urine measurement, which is technically difficult, and the 24-hour urine collection, which is also difficult and need for careful collection by a subject, will not needed in estimated GFR. And for this reason, estimated GFR is more accurate than the measured GFR. Several equation was obtained, as I mentioned. The earliest one is Cook-Croft and Colt equation, and there is a modification diet, renal disease, MDRD, and chronic kidney disease epidemiology equation. The earliest one is Cook-Croft Colt equation. That is still used till now, mainly in assessing of drug doses to prevent its toxicity in those with kidney impairment. The second one, it is the modification diet, renal disease, which is improved over that of Cook. However, several reports documented that it is valid to use it only to GFR level of 60 ml per minute per square meter. Beyond that, less than that of 60, it become incorrect. The Kidney Disease Improving Global Society have recommended that chronic kidney disease epidemiology equation is the best one that is must be used to estimate or measure or calculate the estimated GFR. Till now, unless an alternative equation can be demonstrated to improve over it. So, it is recommended that the use of chronic kidney disease epidemiology creatinine equation is the best one to estimate the GFR and assessment of kidney injury till now. This for observation only. The equation of each one, some will deal with age and weight and the others will also correct for age and weight and race and gender. So according to type of equation, and there is a ready calculator online that can give it only a weight and age and calculate directly and obtain the estimated G. Proteinuria, the selective permeability of glomululars to protein usually is a complex function of and involves glomerular basement membrane, endothelial cell, and podocyte. In general, protein of large molecular weight, usually more than that of albumin, 66 kilodalton, and of negative charge is retained normally by glomulars and not allow for filtration and referred to high molecular weight. The threshold for permeability of the glomulars is that of albumin, 66 kilodalton, and also the charge is very important because, as mentioned before, the basement membrane is negatively charged and so repel that of the same charge. Low molecular weight usually allow to filtrate in general with certain limitation, and those which are filtrated will be usually retained by proximal tubules and recatabolized to return the amino acid to blood again, because amino acid is essential component. And this that is filtrated by glomulars due to molecular weight low to charge is referred to low molecular weight protein. Normally, there is what is known TAM horseful glycoprotein that is account for 50% of normal lipoprotein daily, and this is resulting from secreted by thick ascending and the early distal convoluted tubules and may be responsible for inhibition of kidney stone formation. So TAM horseful glycoprotein is normal protein that is found in the urine from renal tubular. However, when there is abnormal amount of TAM horseful glycoprotein due to damage of renal tubules and the presence of albumin, also to damage of glomulars, there is a formation of renal tubular cast. Renal tubular cast of different types, usually an indication of renal damage. And the appearance of even very small amount of protein in the urine usually suggests renal disease. Proteinuria classified as tubular, that means presence of low molecular weight in the urine due of high concentration due to the damage of the tubular and inability to reabsorb of the filtrated these low molecular weight protein, or glomerular due to the damage of glomulars allow for leakage of high molecular weight protein and present in the urine of high concentration. So tubular and glomerular. The third type is referred to overflow proteinuria, in which there is abnormal production and filtration of abnormal proteins such as Ben-Jones protein, such as myoglobulin, and disorders that is beyond capacity of renal tubular reabsorption, referred to third to overflow protein. Upper limit of total protein loss in the urine is around 150 milligram to 300 milligram per day total protein, in which albumin is less than 30 milligram per day. So albumin is less than 30 milligram per day in urine, and total protein between 150 to 300 milligram per day normally. International classification of kidney disease defines three categories for albuminuria, expressed as albumin creatinine ratio. Categorized 1, normal A1, normal to mildly increase, in which there is the ratio is 3, ratio 3 milligram albumin to millimole creatinine. Grade 2, 3 to 30 milligram albumin to millimole creatinine, and grade 3, 30 to more than, from 30, more than 30 to more than 300. Kidney disease improves the global categorize another introduce another categorization for albuminuria: normoalbuminuria, microalbuminuria, and macroalbuminuria. Microalbuminuria reflect the excretion of albumin even in a small amount, but it is above the normal range, that is 30 milligram per day, and this small amount usually not detected by a normal reagent strip that is available for measurement or for evaluation of total protein. So when we evaluated protein in urine by a general strip for total protein, microalbuminuria will not be detected. And the microalbuminuria, it is the early stage of diabetic nephropathy, so it is very important to evaluate it with a specific reagent to prevent the progression, loss of renal, and development of macroalbuminuria. Macroalbuminuria, that means proteinuria, which detected by a general strip because the concentration of albumin in the urine is more than 300 milligram. Here, low molecular weight, as mentioned, when appear in high levels in the urine, usually reflect tubular absorptive defect, and there are several parameters that is used for evaluation of tubular damage, like beta-2 microglobulin, retinol binding protein, alpha-1 microglobulin. All of these are of low molecular weight that is normally filtrated and normally will be reabsorbed, but when there is renal tubular disease, will be excreted in high concentration in the urine. The tubular function test, tubular, proximal, distal, also need to evaluate it like that of a glomerular function test. The first one is urinary sodium concentration. Normal sodium in the urine is low relative to the serum unless there is intrinsic renal damage which cannot respond to normally to reabsorption of sodium, so large amount of sodium will appear in the urine in renal damage. Second, concentrating test, usually after administration of pitricine, synthetic antidiuretic hormone, or dilution test after water load. Also use of urine osmolality relative to the plasma, or ratio urine to plasma osmolality, or ratio of urine to urea plasma also can give an idea about renal tubular function. Acidification test after administration of ammonium chloride, also it is very important in differentiation between type 1 and type 2 renal tubular acidosis. Renal tubular acidosis is a group of inherited and acquired disorder that affecting proximal and distal tubules, usually characterized by hyperchloremic and metabolic acidosis. Urinary bicarbonate and hydrogen ion usual excretion is inappropriate to the plasma pH, and of 4 types. The first one referred to distal renal tubular acidosis. As from its name, it is occurred due to defect in the distal tubules, which is usually caused by a defect in the secretion of hydrogen ion. As mentioned in the part 1, hydrogen ion will be secreted into the lumen for exchange of sodium reabsorption. So that when there is a defect in the secretion of hydrogen in the distal, there is what renal tubular acidosis type 1. Type 2, it is a proximal renal tubular acidosis at the proximal tubules in which there is a defect in reabsorption, formation and reabsorption of bicarbonate. Type 3, many workers abandoned it, and so there is type IV, which is usually occur secondary to aldosterone deficiency or resistance. Action of aldosterone that occurs at collecting duct and in reabsorption of sodium in exchange with potassium or hydrogen ion. Usually in renal tubular acidosis, GFR is normal or slightly decreased. Anion gap is usually normal, and usually, however, type 1 distal, there is hypokalemia because of a defect of secretion of hydrogen ion. Also, there is increase in secretion of potassium to exchange with sodium, so result in hypokalemia, hypocytruria, and low urinary ammonium. Why? Ammonium is formed from secretion of hydrogen binding with ammonia, and HF3 to form ammonium. When there is a defect secretion of hydrogen, result in decrease of urinary ammonium ion. Usually pH is greater than 5.5. In proximal, the defect in reabsorption of bicarbonate usually occur infant, accompanied by growth retardation, and maybe one of the characteristic of Fanconi syndrome. In proximal, usually threshold for bicarbonate absorption will decrease to 15 instead of 22 millimole per liter, which result in excessive loss of bicarbonate. Kidney disease is usually used replaced to that of renal, whether for chronic or for acute. Kidney failure is found when GFR is less than 15 milliliter per minute per square meter, and this usually the end stage of kidney that is need for renal replacement therapy or for dialysis. In 2012, a kidney disease improved group defined abnormality in kidney structure and function present for at least 3 months. 3 months damage of the kidney involves structure or function loss will be referred to chronic kidney disease. Less than 3 months, it is acute kidney injury or kidney failure. Usually, abnormality in structure preceded that of function. Most commonly, parameter used to evaluate the kidney function and its progression, it is estimated GFR and albuminuria. Kidney disease improved group society usually stratifies estimated GFR into categories. Group 1, which is normal more than 90 milliliter per minute. Group 5, it is the end stage when the GFR is less than 15 and need for renal transplantation or dialysis. In between, there is group from 3 to 5, and also subdivided according to the rate of glomerular filtration and also to the albuminuria. Albuminuria also categorized into group 1, less than 30 milligram per day. Group 2, 30 to 300 milligram per day. This is microalbuminuria, usually not detected by normal available strip, which detect only a proteinuria when it is more than 300 milligram per day. And this range 30 to 300 is very important to be detected by specific reagent as mentioned to early detection of diabetic nephropathy and prevent it from progression to macro and for correct of hypertension of diabetic patient. Group 3, when there is much amount of albumin excreted in the urine, more than 300 milligram, and referred to proteinuria. The most common causes of chronic kidney disease is diabetes mellitus, account for 50%. So as mentioned, it is very important to detect the early stage of diabetic nephropathy by microalbuminuria. The second is hypertension, account for 25%, and the remainder may be due to glomerulonephritis, due to nephrotic syndrome, to systemic infective, interstitial, or other causes of. Here we will talk about the markers of reduced function or damage. These include, again, reduced or decreased glomerular filtration rate, and mainly evaluated by estimated GFR, and usually is less than 60 ml per minute. There is albuminuria, which is usually more than 30 milligram per day, or more than 3 milligram per millimole albumin creatinine ratio. Also, there is electrolyte imbalance, including hyperkalemia, hyponatremia due to the damage of renal tubules and the lack of aldosterone action by defect in response of renal to this hormone at collecting duct. Also, there is hyperphosphatemia, hypocalcemia due to the lack of response of renal diseased renal tubules at distal tubules to the parathyroid hormone action and lack of the channel for reabsorption of calcium. So there is hyperkalemia, hyponatremia, hyperphosphatemia, and hypocalcemia, which may occur in both acute and chronic kidney failure. There is metabolic acidosis also, decrease in the plasma pH, increase in the hydrogen ion due to the defect in secretion of hydrogen ion, for example, for an exchange of with the sodium ion. Also, this is present in acute and chronic kidney injury. There is anemia, which is a characteristic of chronic and differentiate it from acute, which is mainly due to erythropoietin deficiency due to lack of its production by damaged renal tubules with normochromosity. Also, the most or the best one for differentiation between acute and chronic kidney disease is the increase of parathyroid hormone with decrease of active vitamin D, and this usually occurred and referred to secondary hyperparathyroidism. Kidney disease improved global use the term chronic kidney disease mineral and bone disorder instead of osteodystrophy to reflect the bone and metabolic mineral disturbances that occur in chronic kidney disease, and emphasize that the use of osteodystrophy is only for bone morphology following bone biopsy, while use chronic kidney disease mineral and bone disorder for the metabolic changes that occurs due to renal disease, hypocalcemia, and appearance of secondary hyperparathyroidism. Secondary hyperparathyroidism is a characteristic of chronic kidney disease in which there is hypocalcemia, sustained stimulation of parathyroid hormone to correct this hypocalcemia. The secreted hyperparathyroidism cannot correct the hypocalcemia due to underlying cause, the defect of renal tubule at the distal, as mentioned in part 1, at which the final regulation of calcium is occurred by parathyroid hormone, the loss of a calcium channel due to damage of the renal tubules, and also the loss of 1-alpha hydroxylase enzyme, the activator of vitamin D, and the formation of active vitamin D that is needed for intestinal absorption of calcium and phosphate. So the loss of 1-alpha hydroxylase, the loss of formation of active vitamin D result in defect in intestinal absorption of calcium and phosphate. And the loss of normal channel of renal tubules result in the loss of renal reabsorption of calcium. All these factors prevent the parathyroid hormone from correction of hypocalcemia with sustained stimulation on the gland, result in what? In resorption of the bone to release calcium and phosphate to correct that. The released calcium and phosphate cannot correct the condition because more major amount of the released calcium from the bone will be excreted into the urine, result in what? Secondary hyperparathyroidism, still hypocalcemia with bony erosion, and intramedullary cysts are seen in X-ray. Also, the World Health WHO define anemia as up to 13 in male and 12 in female in pregnant women. Anemia may usually inevitable as to occur in chronic kidney disease. Usually, the major cause of anemia in chronic kidney disease is the loss of erythropoietin from normal kidney erythropoietin, the stimulator of erythrobiosis. The loss of it in diseased kidney result in anemia. The type of anemia usually is normochromic and normocytic because of normal availability of iron and iron storage. Sometimes anemia may be due to loss of iron, and this can be evaluated by serum ferritin and transferrin saturation. In this case, the picture of anemia may differ, may be microcytic, hypochromic, but the major, as mentioned, the major condition of anemia in chronic kidney disease is normochromic, normocytic due to the loss of erythropoietin rather than for iron deficiency. Uremia is what? Uremia is a condition in which blood urea, creatinine, uric acid elevated, that is normally excreted in the urine, will be elevated into the blood. Due to what? To defect in function of kidney, infiltration, reabsorption, result in what? Elevation of these waste product in the blood. It is the terminal clinical manifestation of kidney failure, involved a group of symptoms and signs, and abnormal finding of diagnostic studies, decrease of estimated GFR, increase of serum urea and serum creatinine, that result from failure of kidney to maintain adequate excretory, regulatory, and endocrine function. That means there is also anemia, there is also, as mentioned, bony cyst and bony erosion, elevation of parathyroid hormone, decrease of active vitamin D. Regulation of body fluid is impaired in patients with uremia because of failure to excrete excess ingested when just a large amount of water, inability to excrete that. When there is a low body volume due to vomiting or diarrhea, that is symptoms of uremia, also cannot correct that. So those of uremia, it must be at balance between water intake and urine. Usually acid excretion is impaired. There is metabolic acidosis. The toxicity of uremic syndrome may be related to the urea end product. That's mean product resulting from urea metabolism when accumulating a large amount in the blood and cannot be excreted. Also, however, it is multifactorial, that may be resulting from enzyme inhibition due to uremia, derangement of membrane transport, and decreased ability of the kidney to degrade or eliminate hormone may also have a role in toxicity. Acute kidney injury, it is a sudden decline in kidney function over hours or days, and usually when not corrected for more than 3 months, it is referred to chronic kidney disease or chronic kidney failure. Usually diagnostic criteria for acute kidney injury, what? It is abrupt reduction in kidney function within 48 hours. That is reflected by an increase in serum creatinine by about 0.3 milligram per deciliter. Every 2 days, there is an increase in serum creatinine by 0.3 milligram per deciliter, or an increase about 50% of the basal. That means when we measure creatinine, for example, 1.2, after 2 days, when it is increased by 50% of 1.2 milligram per deciliter, it is referred to acute kidney injury. So the diagnostic criteria of acute kidney injury, either an increase of serum creatinine by 2 days, within 2 days, by 0.3 milligram deciliter, or 50% of the basal creatinine level, and also by a reduction in urine output that's reflected by oliguria, where there is less than 0.5 ml per kg per hour for 6 hours, also indicative of acute kidney. Acute kidney injury may be pre-renal, intrinsic renal, and post-renal. The most common cause of acute kidney injury is ischemia. Intrinsic acute kidney injury also may be caused by primary vascular, glomerular, or interstitial disorder. It is therefore important that all patients presenting with acute kidney injury undergo general urine analysis for infection, for hematuria, for proteinuria. And the most common cause of acute kidney injury is acute tubular necrosis. That is mainly due to ischemia, reduced blood supply to the renal blood vessels or nephrotoxic injury. However, 50% may be due to multifactorial. So the main causes of acute kidney injury is acute tubular necrosis that result from ischemic of renal tubular or due to hypovolemia or due to nephrotic syndrome. Due to nephrotoxic drug. Acute kidney injury, and of which acute tubular necrosis is usually accompanied by anuria or oliguria, and abnormalities indicate tubular dysfunction. There is a primary reduction of GFR that is usually caused by altered intrarenal hemodynamic as a compensatory mechanism that involves secretion of aldosterone and antidiuretic hormone. Why? To retain the water excretion in order to override the decrease of body volume. There is already hypovolemia. So aldosterone secreted and antidiuretic hormone will be also secreted in order to what? To compensate for the hypovolemia and so retain of water into the body. However, this may remain for few days. Otherwise, there is development or progression of a disease. Usually, there is metabolic acidosis in acute and chronic kidney disease. And this metabolic acidosis is usually accompanied by hyperkalemia. Hyperkalemia, which is usually fatal and may result with life-threatening cardiac arrhythmia. This feature of acute kidney failure, oliguria, rising of blood urea and creatinine, hyperkalemia, and metabolic acidosis. Also, there is then polyuric phase, rapid loss of water and electrolyte, can lead to dehydration, hyponatremia, and hyperkalemia. What is the causes? Mentioned pre-renal, which is mainly due to loss of fluid, hypovolemia, what are the causes? Hemorrhage, diarrhea, post-operative, GI bleeding, congestive heart failure, and renal. The most common cause is acute tubular necrosis, maybe due to ischemia, maybe due to drugs, to the glomerular, to vesicular. Renal, which is mainly due to prostatic benign hypertrophy, or maybe due to stone ureter in the ureter or urethra, or maybe bladder carcinoma. As mentioned before, there is a serum or plasma urea creatinine ratio that can differentiate between these three causes, and I illustrated well in part 1. Some appropriate tests to distinguish between also pre-renal and intrarenal. Urine sodium concentration. Usually any pre-renal is normal, less than 20. In renal is more than 40. Why? This is because in pre-renal there is a normal tubular structure and function, and all of the sodium will be retained along with water by aldosterone as mentioned. While in intrinsic there is a tubular damage, so sodium will be not retained by aldosterone by normal reabsorption, result in excretion of much amount in the urine. Urine osmolality also in a pre-renal more than 500, while in renal it is usually less than 40 osmolality of urine. Urine to plasma osmolality ratio and urine to plasma urea ratio, also these four can be differentiated between pre-renal and renal intrinsic damage. Other disease of kidney, glomerulonephritis, is an inflammatory disease of kidney. It is mainly characterized by hematuria, presence of blood cells within the urine during general urine analysis. So we measure that urine analysis, general urine analysis is very important to investigate the kidney disease. There is proteinuria, but it's usually less than of nephrotic is less than 3 grams per day, and there is hypoalbuminuria. Nephrotic syndrome It's characterized by what? Not hematuria. There is low number or count of blood cell in the urine, but it's characterized by heavy protein urea. That is more than 3 grams per deciliter. There is hypoalbuminemia, there is edema. Also, hypercholesterolemia, hypertriglyceridemia, also apparent. Why? Due to compensatory mechanism of the liver to compensate for those lipoprotein excreted into the urine. There is a specific pattern of electrophoresis in which there is a decrease of albumin and other bands of protein. However, in end stage, the end stage of nephrotic syndrome, the only pathognomic indication is the elevated of alpha-2 macroglobulin. Why? Because of its large molecular weight compared with other. The molecular weight of alpha-2 macroglobulin is around 1,000 kilodalton compared with that of albumin 66 kilodalton. So in end stage of nephrotic syndrome, the only indication it is the elevation of alpha-2 macroglobulin and specific band of its in serum protein electrophoresis. Finally, renal stone nephrolithiasis, which may be occurred within the renal or post-renal urethra, and this characterized by what? High concentration of the substance in the urine, يعني accumulation of the substance in the lumen due to the low urine volume or high excretion rate. The pH is very important. Alkaline urine predisposes calcium for deposition, for example during infection, while acid predisposes uric acid deposition. Stagnation usually due to obstruction type of stone. Calcium oxalate and calcium phosphate account for more than 80% of kidney stone. So the calcium is an important component of the kidney stone. Uric acid accounts for 8 to 10%, and in acidic pH, and the other, which is mainly genetic, cystinuria, homocystinuria, and others also account for the remainder part of stone analysis. When there is a stone, it should be analyzed for components that mentioned before: calcium, oxalate, phosphate, uric acid, when neonate infant, cysteine, homocysteine, and other to help in diagnosis. And also, we need for laboratory investigation calcium, phosphate in the blood, albumin, acidosis, also CO2, alkaline phosphatase, or also general urine examination, and may need for 24-hour measurement of calcium and phosphate and urate. Also, renal blood function, plasma creatinine, estimated GFR, and or plasma urea. Table that abbreviate the change of parameter in respiratory and metabolic acidosis. Two cases you must read and define the type of disease, the result. And thank you very much.